Today I'm going to do a 30-minute overview talk on market design in healthcare. So a really simple topic for 30 minutes. And I think at the start, it's useful just kind of going over some high-level points, which I'm sure many of you are familiar with. One of the key points, which is probably the case for many of the sessions that we're going to have in this conference, is that free markets with limited regulation really do struggle to deliver in healthcare. If you think about kind of the classic Econ 101 type market, and there's a couple of reasons for that. One reason for that is that the right to care or the desire to make sure that people have access to care, essentially it implies the need for non-price rationing, okay? And the second reason that's in play, especially in kind of more privatized versions of healthcare markets, is you have issues related to adverse selection, especially in insurance markets. You have issues related to moral hazard, and you have significant issues related to information asymmetries, not just in insurance markets, but also in provider markets, going all the way back to kind of Arrow's seminal work on that point. And so there's quite a few examples of specific topic areas in healthcare where market design has already delivered kind of successful research and successful results. I'm not going to talk about the residency match, which is obviously one of those areas that we heard about earlier today, but two areas I'll touch on where I think there's been a lot of success, but also some nice areas for future work are health insurance markets, so health insurance market design. And the second area, which Rachel touched on earlier, is vaccine supply. During the pandemic, not during the pandemic, there's different issues in both of those cases, but both are kind of very important for market design, or market design is very valuable. In addition to those topics, which are a little more studied, I'm going to talk about some new directions or new areas that I think are potentially very promising. And those include things like payment models for gene therapies, which are an important kind of direction going forward, but also a stand-in for kind of high-cost curative drugs in general. I'm also going to talk a little bit about outcomes-based payment models for drugs and providers, robust paternalistic choice aids, and I'll kind of explain what that means. And then addressing provider deserts, issues where there's kind of limited access to providers, and which is in some sense a market failure in certain settings. Okay. So I'll start on the first topic, which is health insurance market design. This is an area I've worked in a lot. And over the past 30 years, there's been both a lot of research, but a lot of policy implementation of this research and pretty deep connections between the policy and the research, okay? And a lot of both the policy and the research has really moved forward over the past 30 years or so, I'd say. When we're thinking about market design in this space, there's a lot of competing factors or a lot of competing objectives that you think about as a market designer. One of those, especially when you're thinking about market design with using private markets, is how do we set up a system where there's competition that delivers both price, kind of cheaper prices, as well as better product quality. There's a lot of concern, as I mentioned, in insurance markets about adverse selection, where essentially the relationship between cost and risk leads to potential under-provision of more generous insurance coverage on the intensive margin and selection out of the market on the extensive margin. There's a key objective of redistribution, equity, which I referenced before. And then kind of layered under all of this, there's significant issues with consumer choice quality. Consumers have choice quality issues in insurance markets, choice quality issues using insurance, choosing doctors. And so these are kind of a core set of objectives that policymakers and economists think about. Some examples of kind of how these principles have been applied in practice. There's many markets where these things have been applied. Some kind of core large examples include Medicare Part D, prescription drug insurance for consumers in the US, which uses a lot of kind of market design principles from the literature. The ACA exchanges covered California as kind of one example of an exchange style market in this space that's been heavily influenced by market design. And then this is not just a US-centric market design issue. For example, countries like the Netherlands have applied these market design tools in the context of kind of quasi-private public regulation. So in this space, with these objectives in mind, what have people studied and where has a lot of the work focused so far? And there's been a lot of work in these areas, but there's also quite a lot of room for future work as well. So on the left here, you see kind of different tools or different topics that people have studied within the context of these markets, which are kind of specific applications of market design tools. So one aspect that I've studied quite a bit is contract pricing and duration. So there are some of the variables you think about as the market designer is to what extent should price discrimination be allowed by insurers in this market. The more price discrimination you allow, the more equity concerns you have, the more concerns you have about consumers being reclassified year to year, so-called reclassification risk. But when you allow more granular pricing, there's less adverse selection kind of holding the rest of the things in the market equal. Okay, so that's kind of an important trade-off with contract pricing that's been studied. Contract duration is also an important issue that's been studied. So in many markets, health insurance contracts are regulated to be 1 year at a time. And most people, when they study health economics, they kind of take this as a given for the first year or first 2 years. And then at some point, I've advised many students, you see them, the light come on and they ask this question, well, why 1 year? Why not 6 months? Why not 2 years? Why not 3 years? I think this is an interesting research and policy area. I have some recent work, the Gilly et al. Paper referenced here that thinks about long-term contracts with one-sided commitment on behalf of the insurer in this market. And there's all sorts of issues where when you think about kind of making the contracts longer, it's good for cutting through this trade-off I mentioned between adverse selection and reclassification risk in the 1 year at a time market, because you can allow for more upfront price discrimination. But it leads to all sorts of other issues where you need to have the insurers front load the contracts in this one-sided commitment environment. And then you're charging consumers more upfront, which brings up life cycle income issues and kind of more macroeconomic issues. So that's one area. In addition to that area, a topic that's been studied a lot is subsidy design. So subsidy design, it's important, of course, directly for equity consideration. So how much of a subsidy will you give in these markets for consumers of different income levels? There's also been quite a lot of research on how should you structure these subsidies. So should they be fixed subsidies that require consumers to pay the full marginal cost of insurance premiums in the market? Or do you want to tie the subsidies to the premiums also on the margin in some way? There's a really nice paper by Mark Shepard and Sonia Jaffe that studies this difference and thinks about kind of how policymaker uncertainty trades off with giving consumers kind of the full kind of marginal internalization of the premium in the market. In addition to subsidy design, there's been a lot of research on frictions, and in insurance markets and some other markets, selection markets like credit markets, choice frictions have in and of themselves, they cause an issue where consumers aren't necessarily matching to the right products. That can lead to issues where insurers aren't dropping prices or innovating as intended. In addition, in selection markets, there's an additional issue where as consumers are making kind of less informed choices or choices where frictions are more present, it can actually help hold the market together by kind of mitigating issues related to adverse selection. So there's a literature where when regulators think about implementing choice tools in this space, they have to be very cognizant of the implications that could have for adverse selection. I'll talk about that a little bit more on the next slide when we talk about tools like targeted defaults, which are kind of powerful tools for impacting consumer choice quality. Finally, two other areas to mention are kind of product regulation, which is really relevant in healthcare markets where we're thinking about just defining what are the products that insurers are allowed to offer? What's the actuarial value that's allowed? What services do they have to cover? Are they required to cover? How do we structure cost sharing in Medicare Part D plans? These are important features because due to kind of aspects related to research like Rothschild-Stiglitz screening models, et cetera, and selection market models, if you allow insurers to offer whatever they want in terms of quality, whatever they want in terms of product variety, there's significant issues related to cream skimming. And so the product regulation aspect of these markets is very important. Finally, I'll give a quick mention to what I call adverse selection corrective policies. And so here there's been a lot of research on things like the individual mandate in health insurance markets and risk adjustment schemes which essentially reverse intensive margin adverse selection in these insurance markets. And these are market designer tools that are used in tandem with the other tools you see here on this list. So that's kind of a sense of research that's been done. A couple areas that I'm interested in going forward. One question, which is, it's not exactly a market design question, but it's very important for the consequences of different market design decisions, is this question of what are we getting from private insurance markets at all? And so there's a presumption in the market design setup of many of these markets that the reason we have private insurance markets is that insurers are going to innovate, they're going to offer differentiated products, they're going to do things that are going to be different than one another, that's going to deliver value to the healthcare system. That's a kind of a natural thing for economists to think. It's in some sense, I think it's a big presumption. And so there's very limited research actually quantifying insurer productivity, insurer innovation, insurer differentiation. But I think it's an especially important topic when we think about kind of different aspects of how to deliver value through the privatized markets here. In addition, on the choice dimension, I think an interesting question going forward is whether we can leverage benefits from private insurance markets using more aggressive choice aids. So there's omnipresent, ongoing discussion. How can we help consumers make better choices in these very complicated markets? Most research shows that any tools that are really pushing tools, so consumers where consumers are going to actively engage in the market, are unlikely to cause more than 15 to 20% of the people who have choice issues to re-optimize, right? Targeted defaults or default options in general are a much stronger strategy. The data is out there to design individual specific default options that can really help consumers avoid cases where they're losing $1,000 for sure by choosing a plan or something like that. But there's a lot of issues, I think, that haven't been studied related to robust design, where if you're creating an algorithm that's going to really strongly help steer market share in these markets, what are the implications going to be for how firms compete with one another? How can you make this design robust so that firm gaming of this algorithm doesn't outweigh the potential benefits from moving market share towards more efficient options? So I think there's some interesting things there. The last thing I'll mention in the insurance space is that is the question of what are the implications of vertical integration. There are many kinds of vertical integration between insurers and other firms. The kind I'm kind of specifically interested in here is vertical integration between insurers and medical providers. In the past 5 years, there's been significant concentration and movement for insurers to integrate more with doctors up and down the supply chain of healthcare. And there's very little research in this space, but it's kind of easy to see how that kind of vertical integration can impact a lot of the design decisions in insurance markets and a lot of design decisions kind of in the healthcare markets in general. So moving on to the next topic, which is vaccine supply. Rachel teed this up earlier with her discussion. And I think here, this is a topic that I felt was very important to mention as an area where there's been progress research-wise, but also where there's a lot of scope to make progress going forward, as Rachel mentioned earlier. And so here, kind of two leading examples of things that were mentioned before. One of them is the pneumococcal vaccine advanced market commitment pilot. And so Rachel described advanced market commitments earlier. Advanced market commitments are essentially a tool where you're promising to buy a certain amount of units of this vaccine from a supplier and essentially giving them a pull or an incentive to come to the market, offer that product at low cost, and then give them a share of a donor pool or a fund that's related to their capacity that they've committed to. So this is a very classic example of market design that's also been very influential in practice. And the literature here thinks about pull funding, where advanced market commitment is one example, as well as push funding. And these different types of funding and how you kind of decide between these mixtures of funding, there are a lot of variables in the market that depend which of these mechanisms you want to use. So is the technology that you're trying to bring to market very close to reaching the market? And so are you trying to incentivize increased capacity? Is it very far from the market? And so are you trying to incentivize R&D? And so as a regulator or as an organization setting up these funds, this mixture of push and pull funding, how you use these tools, I think it's an especially impactful area and especially interesting area for research going forward. This figure here relates to the pneumococcal pilot, advanced market commitment, and shows that whether or not it was caused specifically by the advanced market commitment, this is a very successful area where poorer, lower income countries really gain significant access to this vaccine after the deployment of this advanced market commitment. Okay. Rachel also talked earlier about vaccine supply in a pandemic. Here, I won't kind of belabor the point too much. I think that the really interesting aspect of this, which was mentioned earlier, is that the vaccine supply in a pandemic, some of the design issues, some of the market design issues are quite different than vaccine supply, for example, for the pneumococcal vaccine deployment. And one of the lessons from this literature that we've seen across several papers is that one of the key factors is in a pandemic, you want the regulator to incentivize capacity building in parallel with the clinical trials for the vaccine. And in fact, even more recent research has motivated the use or the need for building capacity in quote unquote peacetime in order to be prepared for when the next vaccine occurs. So essentially using capacity building and those kinds of push incentives for capacity building as a tool to be prepared for when kind of the next pandemic happens or something like that. Okay, so those are two areas where there's been successful research so far, as well as a lot of work still to be done. An area that's a newer area where I think there's going to be a lot of room for research and a lot of room for research to connect to policy is payment models for gene therapy. Here for gene therapy, you could also kind of substitute in high-cost curative drugs that also kind of generate lots of savings in the medical system after these drugs are taken. In gene therapy, it's essentially a leading example of novel drugs or novel therapeutics that either cure diseases or kind of greatly front load the cost and the benefits related to a certain disease profile. So these kinds of drugs can potentially deliver significant value, but they're very expensive. So they come with a very high sticker shock for consumers and for policymakers. Two examples I have listed here. One is, these are both approved drugs. One is Zolgensma, which is a drug for spinal muscular atrophy. This is a drug that's given to children for a very debilitating disease. This drug costs $2.1 million. So you can see why that's kind of, you can see the sticker shock element here. But it's a drug that really helps mitigate a lot of the very negative symptoms associated with this debilitating disease. Another example of a drug like this is Luxturna, which they say is priced at $425,000, and then you look and it's $425,000 per eye. You need it for both eyes, and so typically, and so this is a drug that costs roughly $1 million and is used to treat inherited retinal disease. So these are drugs that have the potential to deliver really high value. Okay, you can see here a chart from recent research by John Gruber and co-authors. It shows that right now, the cumulative cost of these drugs, if you kind of start from the present day, the kind of marginal increase in public spending or overall spending on these drugs, it's not that high. But as you go up over time, more of these drugs are coming to market. You can see that the cumulative spending is expected to kind of go up and up and up. And the y-axis here, the scale is 10 to the 11, so hundreds of billions of dollars. And so you can see that this is a market where there's kind of significant cost and significant scope for policy to think about kind of important issues. One of the issues in this area I think is kind of especially interesting is how private health insurance coverage in the US will interact with this type of treatment, which is very high cost but curative. Some kind of facts that I think make this an interesting market design issue. First, churn across insurance products is very high in the commercial US market under 65. Some studies suggest it's roughly 20% per year, people switching across insurance carriers. Second, as many of you know, patients many patients, most patients switch insurers or payer sources at age 65 when they're typically moving from private insurance to Medicare, which is government insurance. And then a third important factor is that coverage rationing or coverage denials. These are kind of key strategic variables for insurers when they're thinking about their policies that they're applying to consumers. So an implication of these three things together is that insurers essentially aren't incentivized to internalize kind of the long run benefits or costs of their consumers. They're more focused on the short term, especially in private markets. And if you think about that, about the fact that they're incentivized to think more about the short term, that means that these treatments where you might spend $2 million up front save money in terms of net present value, of course, save lives, save kind of quality adjusted life years. These are things that might not be that attractive to them from a financial standpoint. An additional concern that relates to the churn in this market and these treatments is adverse selection. Without additional market design interventions, if some insurers cover these treatments, some insurers don't, there's a massive dynamic adverse selection problem. Okay, and so some questions I think in this space are a little more specific, but quite interesting, are, what are possible regulator tools or market designer tools to incentivize appropriate coverage? So there's been some discussion of things like long-term reinsurance of therapy use. There's been some discussion of securitization, where basically someone buys the expensive treatment and then either on the insurer side or the consumer side, this is securitized and paid back over time. These are possible solutions, with maybe the reinsurance one being a little more potentially successful. A second question is, should market designers intervene to ensure full participation in some of these mechanisms, so the reinsurance mechanisms or the securitization mechanisms? And a third question I think is interesting is, if you think about reinsurance schemes or securitization schemes, what are the implications of that for drug pricing and also for drug innovation? Okay. And so here, this chart on the right, it's meant to kind of capture some of these trade-offs. Here on the left-hand side of the chart, you have the private market. So the x-axis here is age, with age 65 being the kind of vertical line here. And here, the way I've drawn this, on the private market, you have two types of insurers: the blue insurers who don't cover the therapy, the green insurers who do cover the expensive therapy. They're both due to churn and adverse selection. You're going to get a number of market design issues kind of going vertically up and down in the private market. And then when you think about passing through past age 65 to Medicare, there's going to be a lot of market designer issues that are related to how insurers incentivize that or don't incentivize that. Okay, so I think this is a really promising area for future work. In addition, there's some other topics I'd like to tease that are new and interesting topics, but in a little less depth than the last one. One of these, well, two of them relate to outcomes-based payments. These are areas that policymakers in health have talked about for some time, but there's been quite a lot of difficulties, I think, implementing really successful policies related to outcomes-based payments. One of the main reasons for that is measuring outcomes has proven to be very hard, both for providers as well as for successful drugs. In the provider space, there's an additional issue where patients are often seeing many providers, so attributing outcomes to specific doctors is a challenge from kind of an incentive design and market design standpoint. So even though there's been some significant attempts, like accountable care organizations and insurer-driven pay-for-quality programs, this is still an area where I think there's a lot of room for research and a lot of room for thinking about kind of the information asymmetries and how you want to design these kinds of pay-for outcomes programs. In addition to that, at kind of the more macro level on the drug side, I think there's interesting market design questions related to reference pricing. So many markets, either in the US or many countries, use drug reference pricing as a way to hold down drug prices as kind of a default or de facto negotiation tactic. And so a typical reference pricing scheme will say, we'll pay you X dollars for this drug, and X dollars is kind of exactly what private insurers in the US are paying, or the lowest price being paid by private insurers. or the lowest prices paid by this other country, or the average price paid by this other country. So this is an interesting area for kind of thinking about research and market design, because there's kind of significant issues related to optimal design of these programs in equilibrium. Are you internalizing the externalities that your program causes on the initial prices or the drug prices being given in the other areas? For example, if many countries have aggressive reference pricing, then drug manufacturers in the reference markets will want to raise the prices in those markets. And so that's an interesting market design question. Okay, a couple other topics that are in health markets. One is quality scoring design. And so this is a really important topic in both insurance markets, so trying to rate insurers based on quality, as well as provider markets, rating providers based on quality. There's been some really nice new research in this area by Ben Vatter, who is somewhere here. And here, there's a lot of interesting market designer issues. How do you want to set the quality scores? If you're thinking about levers, what do we want to measure? So have inputs into these quality scores. How granular do we want these measures to be? And are regulators going to layer incentives on top of kind of the measures themselves that are given to consumers in order to incentivize insurers or providers to kind of change their quality in line with these tools? Factors that these tools impact include supply elasticity. So how are you going to supply quality as an insurer or as a provider relative to these quality scores? How do consumers internalize and interpret these scores in the marketplace? And what are their demand elasticities with respect to these scores? Another area that's a separate area, but I think has been understudied, is the area of provider deserts. And so here, I'm thinking about markets, which in these provider deserts I'm referring to, they can have different causes. There can be different reasons. You could think about the lack of providers in rural markets in the US, where this is a big issue. You could think about a lack of mental health providers, which, especially in the past 5 years, has been a major market issue, where in many areas consumers have essentially no access to this kind of provider. And so thinking about how you deal with this issue, whether it's relative to entry requirements for labor into these markets, whether it's regulation of insurer networks, whether it relates to, do you require doctors to participate in certain programs like Medicaid if they're going to participate in private markets? There are a lot of important levers here, and these things will ultimately end up impacting factors like labor preferences, who gets access to care, what's the cost of care, what's the quality of care, et cetera. So I think that's another interesting area. Okay, a couple final topics to mention. I mean, I missed the biggest topic up front, even though I mentioned it a little bit, which is that, countries, when they're thinking about designing their overall healthcare system, this is in and of itself a huge market design problem, right? And countries do this very differently than one another. The US is a very specific kind of top-down market design, which is more based on private markets. The UK, Sweden, countries like that have more nationalized markets where both the doctors and the insurance is basically government run. You have intermediate versions of the systems. And then there's also been recent developing country research that shows how those market design issues at the national level interact with development issues like bureaucratic constraints, limited bureaucratic capacity, and things like that. Okay. So I'm out of time. Let me wrap up. I think hopefully this teases some of the interesting research that I hope will come going forward in this area. I think if I was kind of trying to advertise for working in healthcare market design, I think we're pretty far from the frontier. Even on kind of the set of current topics that people have been working on, there's still a lot to do. But also this is a rapidly evolving sector, as you saw with the example of gene therapy. I didn't talk about the role of AI in healthcare, but that's obviously going to have a very important impact over the next decade or even sooner. There's really tight links between the research that's been done in healthcare and healthcare policymaking. We see that in insurance markets. We see that in the vaccine markets. I think that's something I personally love about working in this space, is that you can do really interesting market design conceptual research and really get people to listen in terms of what you're doing. And you can use a range of tools, right? Matching tools, auction tools, tools related to design with asymmetric information. The last thing I'll mention, which I think is an important aspect, is that I think the market design solutions in research, researchers should really work to kind of emphasize and think about the robustness of these tools with respect to kind of key environmental issues and key implementation factors. I think in the talks this morning in the energy and environment, we heard a lot about kind of the political economy of tool implementation. And I think that there's more room for that in this kind of healthcare research, thinking about not just what's the ideal way to design it as an economist kind of sitting in my office, but also, you know, say we have to change one of these dimensions because of political economy or alter one of these dimensions. What will that imply for the way I'm thinking about this market design? Thank you.